Hello, everybody, and welcome to the Smart Human Podcast. On today's episode, I'm speaking with friend and colleague Dr. Mikhail Kogan, Misha, as he's called, who is an internist, geriatrician, and palliative care physician, as well as integrative medicine and a specialist in medical cannabis. Today, we're going to talk about geriatric medicine, what we should know, as well as medical cannabis or medical marijuana, its regulation, formulation, health benefits, and much more. So please stay tuned. Hello, everybody, and welcome to the Smart Human Podcast. Today, we have a special guest, Dr. Mikhail or Misha Kogan. He is board certified in internal medicine, geriatrics, and palliative care, and integrative medicine. And he's a leader in the newly established field of integrative geriatrics. Dr. Kogan is currently the medical director, actually, of GW Center for Integrative Medicine, associate director of geriatrics and integrative medicine fellowships at George Washington University School of Medicine. And he happens to have been an early adopter of medical cannabis. And we're going to be talking a lot about medical cannabis and different types of marijuana and how it's changing or it's being changed across this country in terms of its acceptance and also how it's being used medically. So we're going to get into that as well. Welcome to the show and the podcast, Misha. Thanks for coming on.
Happy to be here. Thank you.
You're welcome. And so Dr. Kogan and I, Misha, have known each other for a good amount of time, actually. So he has written the book Integrative Geriatric Medicine for Oxford University Press, the textbook, similar to the Integrative Environmental Medicine that I wrote with my co-author. And he's soon to write, I believe you're in the middle of writing the consumer version, right? Okay, of Integrative Geriatric Medicine, which will be available to consumers and I think will be really quite interesting because, geriatric medicine is so interesting. In fact, why don't you tell us a little bit about geriatric medicine? Because some people haven't even heard of the terminology, actually.
Well, actually, that's maybe good that they haven't because we're actually trying to get rid of this term. It's, especially with the view that getting old is not necessarily associated with getting sick. So I think the idea is the term always implied a disease of an older adult. And I think the whole field is shifting towards staying healthy, living longer. So there are different terms. I think we're now trying to simply say older adults, or sometimes, you can use words like wisdom, wise. I personally like the term age-wise. That's kind of the term that I coined. But, I think the reality is the current practice of geriatrics, the way, if you go to a regular geriatrician, you'd sort of be managed in a very medical model. The problem is that in older adults, the disease management shifts a bit. I mean, there's just not a lot of curing. There's not a lot of disease modification. But since we're continuously applying our typical diagnose, give a drug and go send person home kind of model, very standard diagnosis and treatment, unfortunately, there's a lot of overprescribing. There's a lot of toxicity in the geriatric population. And, we know that about 200,000 people die every year from correctly prescribed medications. I'm not even talking about overdoses. I'm talking just, expected risk of side effects of everything we do. So something called iatrogenicity. And so majority of the patients who die are actually older adults. And so I think I've been on this gig now for some time to say we need to move the practice of geriatrics to a holistic practice and towards deprescribing, and not just deprescribing, by finding the integrative alternatives to give to patients to manage their conditions.
Yeah. And in fact, as people age, you would kind of expect that as people age, people get sicker and people get more medications from various specialties and different specialists. And they develop what's called polypharmacy, which is what you're describing is just so many prescribed medication. And it's very hard to get patients off of these medications once they're on. But what's also interesting is that they're often, older folks, elderly people above 65, as it's defined, aren't even included in many of the studies that are looking at toxicity or safety of these medications. Is that true?
Exactly. No, absolutely. And, since I've been following your work for quite some time, and I'm also personally very interested since, I don't know if we want to get into this, but I had my own personal standing issue with mercury when I was in my 20s, and it's almost, didn't kill me, but it basically defined my life path. But, I see the toxic picture in 65-year-old patients, probably in half of older adults, if not more. And so it's extremely common problem, and yet there's no real standards of care. There's no tests that are, covered universally by Medicare. So it's a very complicated topic in itself. And, I think, unfortunately, a lot of the problems that are starting from the toxic and then move to somewhere else, they're just never really managed. So they never addressed at the core of the actual problem. They're just managed with yet medications. And then just to kind of address your point, Ali, by the time a person reaches 65, they have almost 50% chance on being on 5 medications or more. And I mean, that's kind of scary if you think about this, that half of our population is taking more than 5 meds. I'm not a computer, but even a computer will have a hard time figuring out, intricacies of interactions with foods between the drugs. So it's a kind of an unprecedented experiment of the standard of care that, I hope that will change.
Right. So along that line of thinking, not only do we have chemicals from medications, because medications are chemicals that are tested, by the FDA as a singular chemical and for outcomes for that drug, but they're never tested as a mixture with other medications, which are often the case, as you're saying, 5 drugs by 65, but also not along with the chemicals that we have pervasively in our environment, such as the food chemicals that we ingest, or air quality chemicals, pollution chemicals, or chemicals from products that we put on our skin or furniture. So, we now have some pretty robust information showing that those chemicals may in fact either exacerbate some of those drugs and side effects of those drugs. So it's a really, it's interesting. So I guess the punchline is what you do as well, which you're on the board of the American Board of Integrative Medicine, is to work.
Not anymore, thank God.
Oh, you're not on the board. Okay, all right. That
no.
It's
not thank God. It's just it's a lot of work. So I've put about 5 years into it when it started back in 2012, but I've been off of it since 2017.
But you put your time in, and you're invested in integrative medicine, clearly from your position and your history of study and training. The punchline often is, well, how do we get people off these medications? How do we scale them back? Is it through what we and you and I both would consider lifestyle changes? And has that been your experience? Have you been successful in doing so with many of your patients?
Well, I think in a standard practice of geriatrics, there's this concept of deprescribing and a quite aggressive teaching of the next generation of students and fellows and residents on how to do it. Well, the problem is, you can deprescribe certain things. Well, let's say somebody is overtreated for hypertension. Well, that's pretty easy. But what if somebody has pain? I mean, you can try to deprescribe narcotics, but then what? I mean, what are you doing alternatively? Are you helping the patient to manage their pain or not? And so the problem is there isn't too many alternatives out there quite often. And in geriatrics, it's even more so. While in younger population, they may change to another medication that's safer, or they may simply decrease the dose and it'll be fine. But in older population, unfortunately, often that's just really not possible. And then the alternatives are not offered. And yet, in integrative medicine, since I brought up the pain, I mean, there's so many different treatments, acupuncture and body-based. And then you also run into issues of the cost. A lot of the older adults are on a limited income, on Medicare, and Medicare doesn't necessarily cover a lot of this modality. So you also run into practicalities that even if you know how to manage patient well, you may not be able to do it from practical perspectives.
Because they can't afford acupuncture, because Medicare doesn't cover any of these modalities. They are in the VA system. I think they're getting closer to doing more of that.
But it's getting better. Yeah. It's getting slowly better. Medicare actually is legally now covering acupuncture as of last year, but it doesn't mean that they haven't established the system to pay acupuncturists. And frankly, it's not even clear if acupuncturists will be signing up, because if they pay $25 as they pay for chiropractic care, I'm not exactly sure who's going to agree to work with that. So, but it's moving. It's slowly shifting forward. I think I think the opiate crisis have dramatically shifted the field. I mean, there's a lot of innovative approaches. There are a lot of pushes. There are a lot of research happening. And of course, we're going to talk about cannabis, but it also plays, in my opinion, very substantial role in care of the chronic pain.
Yeah, we're going to get into that in a big way. I want to pick your brain for some other topics that I actually encounter, which is, as patients get older, 65 is sort of this critical age where physiologically blood vessels get stiffer. And there's some, really kind of interesting data showing that even blood pressure should be a little higher than below 65, so they can perfuse the brain, get that blood against gravity up to the brain so people don't fall, which fall precautions, falls are such a major problem in this country in terms of, medical management and cost and outcomes. But also statins. A lot of people on statins, there's some question as to whether or not they too should have higher LDL cholesterols. They should be a little bit more padded in terms of their weight. Instead of being frail elderly, they should be really kind of a little thicker if they, fall and they have a little cushioning. What's your thoughts in terms of readjusting the standards of what we consider for under 65 blood pressure, statins, and weight versus what you consider is, kind of a general rule for older 65s?
Well, I mean, even in a standard of care in geriatrics, I think our typical standard for management of blood pressure over 65 is, just to get patients under 150. I don't systolic. I don't think there's any reason to try to push much further down. You're absolutely right. I actually not necessarily think that the problem is needing to keep the blood pressure up just because of stiffer vessels, but because you're running risk of dropping blood pressure, having a fall, which would be much worse complication than, occasionally having blood pressure in 160s. It's just, your ratio of risk to benefit in older population dramatically changes. I mean, if you take a 30-year-old and you say, well, what's the chance of them falling down, having a hip fracture? It's a one thing. If you take a 75-year-old, if that person has the hip fracture at that age, chances are they'll never fully recover. In fact, if they don't get surgery, they're 90% dead in 1 year. So, you have certain things that a general public, and I would also say general practitioners, often simply not very well aware of. And I think there's been shift over the years. I think American Geriatric Society, as much as they're very conservatives and don't necessarily like a lot of things that I do, but I give them a huge credit that they've been very aggressive at educating politicians and general public and other providers, saying, look, older adults, we can't treat them the same way we treat everybody else. And I think that's essential. And the other thing is with the falls, we also know that the problem is it's not just the side effects. It's not just you falling down and that's the problem. I mean, the people get isolated, they get feared, they start moving less, so they're rapidly decline functionally. Statins is my favorite topic. Is if there's one thing that I almost got fired multiple times from our university is getting the older adults with cardiologists co-management of trying to get them off the statins, and the cardiologist calling the chair of medicine saying, this guy has to go, he's crazy. And, and the problem is they may be right if you're 45 or 55, but if you're 85 or 90, the data on statins is nearly non-existent. And the data on statins causing frailty is quite robust. I mean, they're mitochondrial suppressants. It's very well understood, they block CoQ10 production. Not every patient who's on statins will take CoQ10. So, it's a complicated topic. I get older people off statins when I know it's safe. If they're coming in to see me and they're not diabetic and they haven't had a history of heart disease or stroke, and they're just on statin because their LDL is 135, I get everybody off the statin. I don't even argue anymore. I just say, look, this drug is not good for you, especially since I do so much neurocognitive work and I see so many, effects of statins that are negative effects, and they could be subtle. I mean, a lot of people don't realize that often statins cause quite subtle side effects, and until you get your person off of it, they won't even know they have it.
Well, I'll second what you said for this audience, that statins are really problematic in the wrong, they're given out like candy, but, and they serve a purpose in certain populations.
Absolutely.
People who've had heart attacks or strokes, you want to keep that LDL. Apparently the recommendations are less than 70. And there's legitimate reason to keep those blockages from reforming. But when it comes to general public, we're talking about raising, it raises hemoglobin A1C very subtly, so increased risk for diabetes. And also what you mentioned is it lowers CoQ10. And that's often where, as a rheumatologist, I see the myalgias. I get sent patients for achiness. And when you ask if they're on a statin, often it's because they're not put on a CoQ10 supplement or ubiquinol, which is similar, along with that statin. So those are really required. If you're on a statin, you really probably should be on CoQ10 as a supplement.
And if you're 65, you really ought to be on ubiquinol, because past 65 conversion drops dramatically. And so people over 70 has almost zero conversion of ubiquinol to ubiquinol. So everybody should be on an active, biologically active.
On the active form of CoQ10. Yeah. So again, ubiquinol is actually the active form of CoQ10. So I often just use that instead of CoQ10 anyway. So great for clarifying that. So I want to get into some personal stuff back again. So you are a runner, and your father's a runner, and your father's over 80.
Well, he's 85 to be
85. Exact, and so, yep. I actually, we follow each other on Facebook as friends. And I went and scrolled back through Facebook a bit, and I found a picture of you and your dad, you just finished, I guess, the Philadelphia half marathon before COVID had happened. And I think what happened, what was he, second place in 80 and older he finished, and then placed in 75 and older. I mean, he was just
well, there's not a lot of them, right? So it would be a good year to have 10 of them, but and their time is slow. But Dad was never really a competitive runner, but he started running in Russia. When he was in his 20s, he had a bad case of asthma. And, back in 40s, 50s in Soviet Union, they didn't have a lot of good management. So somebody told him, you got to start running if you want to get well. So he did, and he never stopped. So he's done, 50 marathons plus. Then he had a surgery on the back a couple of years ago, and we finally convinced him to stop running the whole marathon, not because he can't, but because now he's getting up to about 7 hours. And it's just crazy for the family to sort of sit and wait for 7 hours for him to be on the race. And so we finally convinced him to start running half marathon. That's also good for me, because I hate full marathons because it's so much training. I don't have time for that. I usually run just halves.
But how does that frame your perspective of your field of geriatric medicine? I mean, I think we could safely say that we're living longer. At least in the U.S. population, we're living longer. I mean, but you might argue we're living sicker. Your father's not an example of that per se.
Nor is my mom. I mean, I think my mom is just a year younger. So I think what formed me doing what I'm doing was two main things. So one is that I don't remember my grandparents. So they all died. My grandfather, my dad's dad, died at 50 with massive heart attack. I mean, he had like 3 heart attacks before he died. So, a lot of my grandparents had a very short lifespan. And even those who lived longer into 70s, I was pretty late kid. My parents it was second marriage for my dad, and I have a half brother. So, grandparents died quite young. So I think I have this niche to fill with older people looking for grandparents and everybody. It was one thing. And then the other thing I realized, if I don't start getting on the wagon of healthy living, look at my genes. I mean, those Ashkenazi genes didn't serve me really well. And so, but, through medical school and later, my parents, in contrast, have always kind of injected the healthy lifestyle in me, even in Russia, where it wasn't that easy. But, Dad started running. I started doing martial arts when I was 10, eating much better and lots of time in nature. So I think I ended up sort of being raised with the idea that just feel well and live well kind of thing. And so, and now that my parents in mid-80s with no medical problems and, except for slightly high blood pressure, for which they both take a pill, and I kind of realizing that, look at the genetics of my grandparents versus my parents. I mean, they've outlived my grandparents now by decades. So that lifestyle that they engaged in served huge purpose. It's pretty obvious. And so I think now both my mom and my dad are huge inspirations for me. I mean, my mom doesn't run, but she walks many miles every day, and my dad still runs 20 hours a week. I mean,
So it argues that lifestyle trumps genetics, like epigenetics, which is really the proteins that allow or not allow within the genes, whether or not that disease comes out from the genes in terms of, so the epigenetics are the proteins that quiet or, could suppress the development of disease. So you're describing maybe genetics that could have some faults, like who doesn't have faulty genes in some place, but then lifestyle kind of overriding that expression. Right. And so, yeah, it encourages people to kind of live healthier and live cleaner and walk and exercise. And so it's inspiring to hear that. And when I see your dad on these Facebook posts, I'm just like blown away because, you don't see that very often. What do you hear most from your elderly population? I mean, I know this seems silly, but when it passes, on Facebook, when you see old people giving advice about life, and what would you say is a general kind of, or one of the common few things that people say older, end of life, about their life looking back in terms of advice, recommendations?
Shockingly, I don't think there's any, I mean, there's lots of themes, but I don't think there's any kind of uniform message. I think there are just a lot of different messages. I think there's a clear message of, don't mind the situations, live your heart, and, express what you want to express in the world, and worry less about what others perceive you at or how. And, that's a big one. I think another huge one is carry something meaningful and find the engagement that motivates you and keeps you going. I think that's a really big one. And frankly, that's also the one that I find quite often as a geriatrician, and also since I do both. I mean, I'm certified in both, in geriatrics and in palliative care.
And tell the audience what's palliative care, because I'm not sure people have heard of that.
So palliative care or palliative medicine is a field of managing symptoms where you don't anticipate person's symptoms going away. So it's basically, you don't try to cure anything anymore. You're just trying to palliate. You're trying to make the symptom be better. And of course, quite often palliative care is associated with hospice, which is only about a half of what palliative care does. And then hospice is sort of a care of a patient and with a terminal illness in the last 6 months of their life or so. And so at university, we have at GW, we sort of all of our faculty are dual certified in geriatrics and palliative. And the reason for that is quite simple. A lot of our patients from geriatrics gradually just over time transition into the palliative care. And, in that last period of life, I think it's extremely obvious for everybody that this kind of the care becomes all about comfort, all about dignity, and what is meaningful there in the past. And what I find quite often, this is where I was going, the patients who are sort of losing their sense of meaning and their purpose, they transition into this end of life a lot faster. And, quite often it's really hard to motivate them back, even if there is no terminal condition. Like we have a lot of people in their 80s and 90s who simply start saying, look, I lived a great life. Now I don't really have, I don't have engagement anymore. And I can't re-engage. And when and this is sort of really non-medical, right? I mean, how do you help someone to re-engage in life? And as a society, we do poorly. I mean, we don't have a cultural setup, right? I mean, in a lot of cultures, when you're older, when you're past a certain age, you become kind of the elder, you become the carrier of the wisdom. We don't value people of great age, and and that's very sad. It's not just sad; it's crazily stupid, because those are the people who carry the wisdom of time, and just to sort of push them and say they're not productive anymore, nursing home, goodbye. It's a part of our general cultural problem, with many other problems we don't have to get into. But I mean, to me, in my profession, I see that as a huge gap, and unfortunately, there's been lots of really great people trying to bridge this gap. Cohen, for example, who started GW Center for Age and Humanities, he that was one of his biggest things. He was basically trying to say, look, how do we engage older? Should we try to engage them with the younger? Is this multi-generational gap? Can we bring, say, kindergarten kids with the nursing home residents? I mean, and unfortunately, those are really voices of majority, but I see this kind of a lack of meaning. And so I always tell everybody when I talk about, what if you were to say, what's one thing most important for somebody who's over 65, I say, stay engaged. And notice I say that even before the diet, the exercise, all these other things, because they come second, because if you're not engaged and if you're not interested in keep moving, those things not relevant
Right.
anymore.
You have to have a will to live and a reason to get up and a reason to socialize. And I often see that with patients. I actually attribute it, not so much to the old age, but even self-esteem and whether or not you're worthy. And a lot of young people, young people or middle, whoever you are in whatever stage of life, self-esteem plays a big role in what you're willing to take on in terms of dietary change or clean drinking water, whether you walk every day. And so, I think if they're not engaged on who they are and what purpose they may feel they have to the world or to themselves or to their children even, it's really hard to get them to, eat more broccoli. It's sort of a secondary issue. But I think that that's something. And also communal living, like you described, I think that's something that's taking on new light where, they're having these housing developments around the world that really incorporate whole families, including the elderly. But it's not really the norm. And I think we've moved away from that at least in the US culture. Even different backgrounds and religions, people tend to put their grandparents in different places. So it's interesting. But I guess what's even interesting is how it ties right now to COVID and, the tragedies we're seeing amongst the elderly that I don't think anyone ever anticipated, and sort of the hotbed of infection that's kind of run through this country in nursing homes and some of the, regulatory and mandated issues that are going into who works where and who gets the vaccine and all that. That's a really an interesting topic. What are your thoughts on, having such a strong connection to the geriatric population? I'm sure you're heartbroken over what you've seen. What are your thoughts?
It's I don't know if we're ever going to see a massive criminal persecutions of the people in power over what happened. The nursing home residents represent, tiny minority of population, but 40% of deaths from COVID. So, and all of those deaths were preventable, like almost 100% of them, because it's just the reality of how in the beginning, especially, nobody had any clue. And I've heard stories that I don't even want to share that they're so scary. Something like when the patient with a known COVID would be discharged to nursing home without being told to the nursing home that the patient was COVID, knowing that the nursing home wouldn't take the patient.
Right.
And then the whole nursing home getting infected. So, there have been, and then of course on a political level, most of the states in the beginning just didn't do enough, and it falls. I don't know how these people can sleep well after what happened. And, and even worse than that, the fact that I don't even see massive changes. Like you think about this, we talk about vaccine, and the vaccine actually should have been given first line to all the residents of nursing homes, not to the healthcare providers. That's my strong belief, because most of the healthcare providers, despite the fact that we're on the front line, look at us. I mean, we are in our 30s, 40s, and 50s. We're much less likely to die from this if we do get it, versus the nursing home residents are the highest risk residents that we have in a country. They should have been given the first priority, but that's not even, the amount of conversation around this topic is suppressed so heavily. It's not sexy topic. It's sad,
And also mounting an antibody response at, chronological age, physiologic age, immunologic age. These are all conversations that people are having, including in my field of rheumatology. What is your exact age when it comes to the cellular level? Does it come from your metabolic process? Is it just, chronologic and you're 75 and you're old versus, someone who's 90 and running marathons on no medications, So it's really interesting, but there's some question about even an antibody response immunologically in older folks, mounting that response. and whether or not they're truly going to be protected. I mean, these are all theoretical. It's way too soon to know. So, it's the jury's out on this, but in terms of who gets what first, I know I'm in line. Are you in line for the vaccine?
Sure. I mean,
I'm not in a rush because I have an outpatient practice, but I certainly see patients that are immune suppressed, except for I would give up my vaccine to someone who's a respiratory tech right?
I would give up my vaccine to the resident of a nursing home in a fly of a second.
Yeah.
Because I feel like, I'm cautious. I know how to correctly utilize the PPP. We have not had much of infection when the correct protective equipment was used. So, but I think the COVID just sort of highlighted the general ageism we have in this country, and the fact that it's just the geriatric population by far is hands down, the most underserved population in the country. I mean,
across all cultures. And in other words,
across all cultures.
Minorities, African Americans, Native Americans, Hispanic. Yeah.
But, it's a general, and I'm not just talking about the fact of lack of resources. I'm talking about everything, lack of research, lack of strategic priorities, lack of planning the urban environment according to them, lack of understanding that we're all going to get there, or hopefully we're going to get there, right? And so planning all of that ahead of time. And, there are societies, like look at New Zealand, for example. The whole country has a perfect plan how that's all organized. And so we are really not spending, we have the most resources, and yet we put so little of them into something that we're all going to be dealing with sooner or later. The reality is, I think this country is stuck on anti-aging movement, which I think is important to some degree, but unfortunately wrong at the core. I'm not saying aging is not reversible or that the science shouldn't go forward, but I'm saying at the moment, currently, most of it is just the empty promises. And when they will be full promises, who knows? But, there are billions of dollars going into that, but not in the current practicality of getting older.
Yeah, it's interesting how the aging has sort of a pejorative connotation, like that that it's not a good thing to get old. We have billion-dollar industry in the cosmetics and rejuvenation and injections and Botox and exercise and workouts. Diet industry. It's interesting that true healthy aging can be pretty seamless through lifestyle and the right information, and you can actually go into aging and have a very small part of your life at the very end that's sick, and the majority of your life quite healthy. And I think that's the goal.
And it's also, we also used to think that, everybody over 75 are kind of old, frail, and reality is people now live 2-3 decades relatively healthy, and compression of mortality in the last year or two for a lot of people is a real deal. I see a lot of my patients in their 90s still, doing almost everything they used to do. And it's exciting, but yet the culture is sort of saying, it just doesn't want to deal with this, right? The culture thinks that there's a term of, instead of science of getting older, there's now a science of staying younger, right? As if they're quite different. But the language here, or the way we describe these things, is actually critically important, because that's how we are sending the message to the society that this is what it is.
Yeah, compression of mortality. That's what I was trying to explain, but you said it perfectly. It's compressing the last portion of your life to be the smallest that actually has illness. Morbidity or mortality is illness or death. So yes, we all want to compress our mortality. And so maybe that should be a new superfood or powdered drink. We'll go into business together. Okay, Misha?
We'll be rich if we figure that one out.
Compression of mortality shakes. Let's change topics. I wanted to cover all that because I just find you fascinating, and I think the audience doesn't always know what it means to be a geriatrician or a doctor that really specializes in older people. So I'm glad you gave us some insight. Now let's change the topics, because this is an area that is really close to your heart. This is something you're incredibly passionate about. You speak all over the country in multiple venues to doctors, to colleagues, to community organizations. I want you to walk us through the different types of marijuana, whether it's medical, whether it's recreational, whether it's CBD, hemp. Can you just give us overviews of each of those to really educate the very basic topic or nuances of this topic, and then we'll get into some of the regulatory issues and changes that are ahead.
Sure. So, well, first of all, thanks for saying word marijuana. I think both words, cannabis and marijuana, are very, very relevant and still used. And even though in the scientific community there's this aggressive push of getting rid of word marijuana, I think that's wrong. I think the word's here to stay. But, when we say marijuana, we really mean, legally speaking, that the plant contains more than 0.3% of THC, or tetrahydrocannabinol, which is what, recreationally we know produces high, or in sort of more medical term, we call that a psychoactivity or psychoactive effect. And, versus hemp is the, nowadays, since the 2018 Farm Bill, the hemp is considered no longer being under jurisdiction of the Drug Enforcement Agency, and so that's less than 0.3% of THC and whatever the content of CBD in there. So when we talk about marijuana, we really mean the plant that has psychoactive enough psychoactive THC to potentially cause psychoactivity, or being high, or if it's used for purely recreational purposes. Now, I'm not an expert in the recreational aspect. I leave it be to those who are interested in that. But we're here to discuss medical part, and then I also don't have a lot of understanding of agricultural processes or growing things, and also kind of some of the legal aspects, even though I find them fascinating. But I'm probably not the best expert on the topic. But I've got involved in this quite almost 10 years ago by now. And the way I always describe to my patients is it's a whole separate field of medicine. Why? Because if you've ever been to dispensary, you'll understand immediately why. Because you walk in there and there is, sometimes in a large dispensary, you can have 50, 60, 100 products, all different for all kinds of different reasons. And if you talk to the bud tender, as we call the clerk, bud tender, BUT, bud tender. Yeah. So,
BUD, bud?
No, BUT, bud tender.
Okay.
Right? Or the bud tender.
Bud.
Yeah,
BUD.
BUD.
Yeah, like the bud of the plant.
Yeah,
I got it.
like
That's cute.
bud.
That's very cute.
Like instead of bartender.
It reminds me of the Charlie and the Chocolate Factory movies, where you walk in and, like the kids see the candy everywhere and the chocolate river, and you kind of walk into a dispensary. I did in Colorado, and I just couldn't believe the lollipops and the brownies, and all the different types of, medical, or I should say marijuana. That wasn't necessarily medical marijuana. Am I correct?
Yeah, but in reality, the sort of in places like Colorado, the difference between medical dispensary versus the recreational dispensary, sometimes you can't even see the difference until you actually start talking and figure out details of each product. But the reality is it's a whole field, and there is a huge amount of knowledge that needs to be obtained before one can start sort of effectively utilize it, working with the patient. The education is lacking. But for patients, I think the critical aspect to understand is the cannabis plant has multiple different clinically relevant ingredients. So some of them what we call cannabinoids. And those cannabinoids, so THC, we mentioned, and CBD, cannabidiol, are just 2 out of approximately at least 100, and some people think up to 200 of cannabinoids. Now, it so happened that our body produces the molecules that are very similar to THC, the main one called anandamide. And so in essence, we have this lock and key. So we have receptors in our body where our own cannabinoid or cannabinoids can fit in and activate certain cascades and help us with all kinds of functions. In fact, our own and the cannabinoid system is way more important than what we call endorphin system or endogenous opioid system. And it's a lot older. It's present in every cell of the body, in contrast to, opiates are not in every cell. And it's seemingly that the system controls almost all of our functions. And some of the most important functions, like pain control, immune defenses, inflammatory responses, so they're potentially critical in some of the clinical applications. And so how is it that we evolved with this plant which is a weed. I mean, there's reason why it's called a weed, right? Well, because back before all the prohibition, it was, and it's like, if anybody ever tried to grow hemp outside, you'd know that it grows like a weed. You don't, nowadays, all the cannabis cultivation is this multi-billion-dollar industry with lights and hydroponics and all. There's good reasons for some of it, but if you think about it, we've lived for this plant for tens of thousands of years, and we co-evolved. The plant's been used for ceremonial purposes, for medical purposes, for recreational purposes, for clothing, for food, I mean, for thousands and thousands of years. And so, evolutionary speaking, one should sort of ask an existential question here. How come? I mean, why is that so that's why I feel strongly that eventually we're heading towards cannabinoids or cannabis, or you can call it an endocannabinoid or cannabinoid medicine, will be eventually a pretty significant field within a larger field of healthcare, because it's so complex, because it has so many relevant directions clinically, and because basically potential for treatments are limitless. Like if you have 60 different products in dispensary, and they're all going to have somewhat of a different impact on a human body, and they could be used for different conditions. And there are thousands of strains. So in essence, and not only that, there's also all kinds of variety of routes. So you can take it orally, you can smoke it, of course, I mean, inhaled. You can use it rectally as suppositories. You can use it topical. You can eat it in different ways, as capsules, as chocolates. You can put it sublingually, which is my favorite recommendation for most of my patients, because my older patients, I don't like giving them anything to smoke or inhale, since possible side effects. But and now that we're talking about the eye applications,
really,
we're talking about that's all coming. So. And of course, now pharmaceutical industry is getting on a bandwagon, because there's huge
market,
financial interest. And so there are drugs that are going to come out of this as well, which would be more of an FDA well, now it almost all looks like there is some hope that things are going to get regulated a little bit more centrally, but I don't know if you want to get into this.
Well, I guess the question I have, just a general question, is, so when it comes to deregulating it in terms of versus, recreational, which I'm in New Jersey, so they're looking to pass legislation to make it not a criminal offense to have any more than 6 ounces on a person at any given time, so you don't have to go to jail. Yeah, wow. 6 ounces.
6 ounces.
Which I read this morning is actually the highest legal threshold of all 15 states that actually have legal marijuana right now.
Yes.
So
6 ounces is probably going to be a full, supermarket.
It's hard to believe, right? I mean, go New Jersey. I don't know. But I guess the question, there's a difference between having medical marijuana push through the political system versus recreational, right? They're kind of separate arguments, and they don't cross over necessarily. Right. I mean, you can have medical marijuana and recreational marijuana in the same state, or you can have one versus the other, correct?
Sure. Yeah, absolutely. I mean, I think the recreational aspect, that's much more based on the politics and financial and, all of that, versus medical. There is I think the idea why more and more states adapting so quickly is because, politicians in states realizing this adds value to the healthcare in a given state. And since federally it's still a prohibited substance, that's the only way for politicians to make it available for their constituencies. And so
so tell us about why you feel so strongly. Tell me about the clinical aspects. Why do you feel so strongly about, and I'm sure you and I are not, alone in this amongst the medical community in terms of what the benefits are and potentially could be. So just give us your experience and what it helps in terms of conditions.
Well, actually, for me, it started because I'm a geriatrician. First and foremost, because I know the sort of critical complexity of people taking medications, knowing how many side effects everything we do can cause, and how often those side effects are not highlighted enough, not discussed enough, and drugs are simply prescribed because that's what we do. And so when I start realizing the level of safety of cannabis, and this maybe sounds a little crazy, maybe it's a part that I grew up in Russia where the cannabis wasn't even part of the conversation for most part. So I sort of got involved into this, not coming through the lens of prohibition era and this whole conversation that cannabis is the deadliest drug. It just was never part of my vocabulary at all. And so when I started learning, I didn't kind of have clean sheet of paper, and it was easy for me to start reading things and realizing, wait a second, it looks very safe, and it looks safe for even really old people. And through the safety lens, I start utilizing it, and then I start having clinical impacts in my patients, and they were so profound. I would get people off drugs so much easier than I used to, like, chronic insomnia, chronic pain, all kinds of abdominal symptoms, skin symptoms. I mean, I can probably sit here and tell you the list of conditions for which I now go to cannabis as a first or second line. It's probably tops 20 or 30 items at this point. So for anything pain related, whether it's an arthritic condition, neuropathic pain, somatic pain, I mean, cannabis now is my first line. For most of the sleep disturbances, it's my first line now. Why? Well, I could recommend them acupuncture. I could recommend them going through the cognitive behavioral therapy for insomnia. Those things are quite effective, but they cost a lot of money.
Doesn't cannabis, I mean, correct me if I'm wrong, does it extend REM stage 4 sleep?
It actually is more complicated even than that. It tends to, because it drops the pain, because it for sure helps with neurotransmitter distributions. So it definitely stimulates serotonergic and melatonergic production. It definitely decreases the pain at night, which, by the way, keeps a lot of people up. A lot of people don't realize that pain is a big deal at night, that people go to sleep after they take, let's say, a pain pill or something. But if the pain is not controlled well enough through the night, you're going to wake up. They're actually beneficial impact on the stages, which is also why I like cannabis versus when you give somebody a hypnotic agent, so drug like Ambien, for example. Those have quite negative impact of running through the normal cycle of sleep stages, and that's quite harmful. I mean, the fact that we not only have more falls with those drugs, and the fact that we have mortality increase, general increase in mortality from all hypnotics. I don't know any hypnotic that does not increase mortality, and they're all on something what's called, by the way, I forgot to mention, on Beer's list criteria. So there's a criteria of drugs that American Geriatric Society highly discourages to be prescribed for people over 65. So all hypnotic
for
agents
fall
are on that
precautions
list.
You're talking about for fall risk or across the board?
Across the board, mortality is much higher. So if you take that drug, you have a high risk of dying, whether it's from fall, from delirium, from or maybe it's just because you may appear like you're sleeping better.
How do you access that? Can an audience member, someone just look up on the internet and find this beer? Yeah, how do you spell that?
Oh, yeah. BEER, Beers. It's not a beer, it's the last name of a person who was a doctor who became famous for it, and it's list. So Beer's list.
Okay,
criteria.
Good. So the audience can look it up if they have a parent or they themselves are aging and they want to go through that med list. They can see whether or not those meds are on that Beer's list and bring it up with their doctor. Good.
Right. So so definitely I started seeing that. But after that, I've spent, when I was on the board of Integrative Medicine, I spent a lot of time with Donald Abrams, who's a kind of a world-renowned researcher on the topic, and also quite a great guy and fascinating speaker. And so I think Donald mentored me in this topic, because I started as a geriatrician in palliative medicine. I started realizing for pain, it's such a profound tool that can be used in so many forms. And I think very quickly, because of that, of course, all geriatricians know significance of having another tool for pain. And so I started I quickly became on our campus a default expert. So I started giving talks and all kinds of referrals. And So, it moved me now beyond those topics. And now I think I've gotten quite interested in skin conditions with topical cannabinoids, which seems to be a very effective treatments for all kinds of chronic, by the way, also even for some rheumatologic conditions.
Right. And I get that question at least, a dozen times a week, should I be on medical marijuana as opposed to, this pain medicine or this or this anti-inflammatory like an Advil, Motrin, Aleve, tramadol, opiates, gabapentin. I mean, there's just so many pharmaceuticals. And then, so the question is, yes, I do believe that there's a role for a lot of these, but I also say it should be done through the medical in the states that do have legalized marijuana. I certainly don't want my patients going to those places as opposed to, a place where they actually have, trained physicians and oversight to, how that should be dosed out in terms of THC. Who should get some THC in their, their mixture? Who shouldn't? I mean, tell me a little bit about, what someone would know soup to nuts in terms of having a physician prescribe it and understanding the questions that go into deciding which formulation would be best for that patient.
Right. Well, there's two separate things. So one is we cannot prescribe cannabis, right? So we have to recommend it because it's still a Schedule I controlled substance. So it's federally illegal for us to prescribe it. What the states have done, they have set up the systems where I, as a physician, would recommend, and patient gets a card from the dispensary. From the state, and then taking that card goes to the dispensary of a choice or a specific dispensary. And, so in essence, I don't actually have a control like I have a control of a prescription. If I prescribe an opiate, for example, I know exactly what patient's going to get. If I recommend the patient to go and get a cannabis for their problem, I recommend they get the card, and after that they go to dispensary, and what they get there, it's up to them, and it's up to the bud tender to sort of discuss with the patient to decide what to get. Of course, providers who are decided to get self-educated, took courses, and are really counseling patients on what exactly should they be getting. There are a lot of us.
But the bud counter doesn't have any formal training? So it could be like a 25-year-old kid that's...
No, it's not could be.
Most of the time, it's a young person that's the bud tender, as you said, BUD. So they basically are the person behind the counter at these dispensaries that are medical dispensaries. And they are the ones that ultimately will help that patient choose which product to walk out with.
Right. Now, they are in front lines. They usually get some basic education. Now, that education can vary dramatically. I mean, there could be some people who've spent years learning this, and they are way more knowledgeable than I ever will be, just because that's all they do, And then, of course, there are some people who are sales clerks that barely have any sense of what that is.
So there's no standardization of training. And so that's something I'm sure you wish would change, because as this sort of rolls out across the country and we have more and more people likely to go to a medical marijuana or cannabis doctor, there's still...
That's actually something that I'm trying to get involved heavily. So we have currently a journal, it's a clinical therapist in integrative medicine. And we created the special issue on professional education in medical cannabis, and our goal is to create set of competencies and then go to the American College of AMC, it's American Association of Medical Colleges, to say, look, you guys have to create a standardized curriculums for or at least set of competencies, so that each university can say, look, this is the minimum that all of our medical students and allied healthcare provider students have to know by the time they graduate our training programs. Right now, some programs do quite reasonably well. Like there's some universities like University of Vermont, University of Maryland, lots of places in Colorado, but if you look at the overall, most of universities have nearly nothing in their curriculum, and students basically coming out saying, look, we don't know anything about it. Nobody teaches us. And even if we had a little bit in a training curriculum, by the time we get to seeing clinical care, there are no mentorship. Mentors, the typical faculty do not tell us how to deal with this. So there's a lot of changes that has to happen. Until then, I feel strongly that the dispensaries are going to be the front line of sort of working with patients, teaching them. Thank God there is some recognition of this in states like Connecticut, Maryland, Colorado, and to some lesser Illinois. So some states have put pretty significant educational components. Like, for example, the Connecticut, you have to have a pharmacist in the dispensary. In Pennsylvania, they're actually requiring a physician to be overseeing all the advices or all the clinical aspects of a dispensation. In Maryland, every dispensary have to have a clinical director who's responsible for the educating of all the staff, sort of what to tell to the patients and all the
because
basics.
on a very basic level, if you come in, it's kind of like, well, if you're on a blood pressure medicine, you're on anticoagulation such as warfarin, and you come in and you don't know whether or not that marijuana is going to change your INR, change your blood clotting capability,
Exactly.
make sure it makes your blood pressure go up, go down, fall precautions if it goes down. And so, we don't even have, even on our, what we look up on, what do I look at, my Hippocrates or something that looks up, drug interactions right there on your your phone, your cell phone, which we do in the office every day. There's nothing that has anything in there about medical cannabis in terms of interactions or what to look for, or, drug interactions, major side effects. So you're talking about a real need here that it's almost like letting the horse out, of the stable,
well, I think it's already out. I think that's not the point anymore. I think the point is how do you control that horse so that it doesn't run into trouble. So, that I don't think that. I think the future of cannabis overall, not just medical, but recreational, is extremely bright simply because the horse is out of barn. There's no question that no political power will ever be able to put it back because of money, because it's such a large revenue generating for everybody, not just for the industry, but for the states that collect taxes on it. And so it's just a matter of regulatory mechanisms and research and a sort of are we going to do this right, or as we say in Russia, or are we going to do it as usual? So that's the future there.
But it's moving pretty fast. I mean, it seems to me that just overnight, New Jersey has just embraced, just even decriminalization of marijuana, and they're actually going to consider, expungement of criminal records and people who were put into jail. I mean, these are really big deal when you talk about the incarceration rate of many people, especially the African American community. So, I think that there's a lot of good that could come out of this as long as they right the wrongs as well. I mean, obviously a different topic for a different time, but your experience with, THC in terms of whether it goes into a product or not, give me a little bit of your thoughts in terms of who should, in general. Of course, everyone listening, this is not for you specifically. You have to work with your doctor. But give us a general, kind of oversight of how you handle your recommendations and the combinations, percentages, and that kind of thing.
Right. Well, I mean, I look at the patient's core set of problems, right? If somebody comes in and they have lots of symptoms that poorly managed, THC for symptoms is almost universally better. I can't really think of any specific CBD symptom, maybe with exception of anxiety, where I would say you're going to be okay with just trying CBD.
And CBD is just the oil from hemp.
Well, so CBD is one of cannabinoids, right? So you can get that CBD from cannabis, so from something that has a lot of THC or some THC, and you can also get it from hemp. And then, of course, there's also separation in industry. There is an agricultural or farm-raised hemp, which is not really it's not regulated by the states as a controlled substance, and so people grow it a lot freer. They can ship it across the lines, mail it to your house. So, and versus you can get the same exact CBD from cannabis, but then it's actually controlled by the state, just like THC, because it depends on what plant it comes from. And so usually when I'm managing symptoms, it's the THC that's sort of the key there. Now, if I'm talking about some specific conditions, and I can give you a long list, but I'll just mention a few. So, neurodegenerative conditions, inflammatory states, which of course you quite familiar with, so rheumatologic conditions. This is where I use a lot of other cannabinoids. So CBD, I absolutely think that CBDa, which is the cannabidiolic acid, is a big one. I think the newest ones are THCA, so tetrahydrocannabinolic acid, and then CBG, cannabidiol. So those are the ones that also seemingly playing bigger and bigger role as we learn about them. So for underlying conditions, and because sometimes, well, not sometimes, usually CBD from hemp is a lot easier to get, and it's a lot cheaper and doesn't require all this complexity of getting the card. And, by the way, getting a card is also tricky, because if you're a government worker, if you're a police person, or if you just want to have a legal way of carrying a gun, if you do report that you have a medical cannabis card, those three things cannot occur. So you cannot hold a government job, be an enforcement officer, or carry a gun, legally speaking, if you, in most of the states. I'm not sure about all, but in most. That's because how it's written, because it's still a federal offense. It doesn't stop most of my patients, I would say, but it comes up almost weekly for me to bring this up and counsel patients accordingly. But, CBD we now use as in combination with other treatments to try to modify diseases all the time. And, whether the research will pan out on some of this, it's kind of hard to say, but patients driving some of this because they're reporting positive outcomes. And part of what excites me about this field is because some of these cannabinoids in the lab produce such a potent core effects, like immune modulating effects, anti-inflammatory effects, neuroprotective effects in case of CBD. They're probably going to end up being a part of a standard treatment for all kinds of conditions in the future. We just don't know the dosing. We don't know the delivery mechanism. We don't know what the ratios should be. Let's say you want to give somebody both THC and CBD. One of the key aspects of CBD, it seems to be quite beneficial to combine with THC. It doesn't directly affect the receptors, so it modifies the way THC works and decreases side effects of THC. So if, let's say, you want to have some benefit of THC, but you want absolutely nothing to do with the psychoactive effects of getting high, if you take enough CBD, it will nullify the THC impact, the negative impact. So, I think the future is really not in the use of any one specific cannabinoid. It's in use of a complex formulas, especially, I'm not even talking about other ingredients in cannabis, such as terpenoids, for example, the smell molecules. So those molecules are often play a huge role because they're enhancing certain effects. So, for example, if we're talking about sleep, certain sedating terpenoids, like the one, for example, that's commonly known in lavender, linalool, can be quite good at increasing benefit of a given cannabinoid.
So Misha, tell me a little bit about the safety with medical cannabis in its different forms.
Yeah, so I think the safety is one of the biggest concerns when it comes, and part of it, of course, goes back to the regulatory status because it's not a drug, and so the way it's manufactured is often quite unique. And so one grower may not use a certain standard practices, and you can have contaminants. I think there's always a big concern for mold contamination, because apparently cannabis as a plant in both dried form, but even when it's alive and still growing, can get mold contamination, which could be very problematic. Of course, we all know mold toxicity is a big problem. And also use of chemicals during the growth of cannabis. So not all the growers are organic. In fact, growing cannabis and hemp organically is not so easy. And while it's getting more popular and easier, but there's still a lot of products out there that really probably suboptimal. And this whole market, the other big problem, if you're talking about hemp, it's just really not regulated well enough. And so you can have bad players kind of creating a bad name, while there is some really good companies that trying to do good. And these bad players could cause a lot of damage to the whole field. And there's no universal standard testing In fact, testing is very problematic because each state mandates that the testing to be done in a given state. Some smaller states may not even have any quality testing companies at all. So they have to either create their own process of testing. They may need to partner with a larger company, which could be very expensive to bring it into another state. So, with the sort of lack of a national standards of testing, there's a lot of problem assuring a quality. And I think that's, for me, always been one of the major concerns. So the way I, in my practice, deal with this, I only work with a small handful of hemp growers that I can say, look, I looked at their products. I tested some of their products myself. So I would, get their product and I would take a little aliquot or a little sample and send it to the lab. And if I like what I see, I say, this is good. And, and I also feel like this is a case where smaller companies may actually have some advantage because they have a way of maintaining the quality and assuring it because they can control the product really well. This sort of kind of an artisan idea of keeping quality better or high. And the medical cannabis, hopefully, states doing good enough of a job. Now, there's word hopeful because it's still not guaranteed. They still may make, even though they typically mandated all of the growers and all of the dispensaries to assure that their products are good and tested. But, until there is a standardized testing requirements that we can compare and say, look, this is adequate, we're going to have this problem continuous. And of course, everybody knows what recently happened, this problem called E-Valley, or this lung damage from vaping of illegal cartridges. Many of them were cannabis cartridges.
Oh, is that right?
Oh, yeah, majority, actually. There were.
Yeah. So for the audience, the concept of vaping and causing such major dramatic lung damage, even in young, healthy, really teenagers, many of teenagers, it turned out was because of the contaminant. It was vitamin E. And of course, it's unregulated. So there were chemicals like phthalates and perfumes and, all sorts of metals that have been found in these vaping formulas. But what you're saying, Misha, is actually there was cannabis in there as well.
Yeah.
And it was also cut with, vitamin E and some unregulated synthetic chemicals as well. Now,
that's a good thing is that none of those were coming from medical cannabis growers. So this is all black market. I think the production within the industry standard, of course, not to use any of those chemicals. But I think the problem, it just highlights the issue that it hasn't been fully solved. And hopefully, as we go forward, this will keep getting better.
Yeah. I mean, I think the movement is so much further than it was even 5-10 years ago. I mean, now you go to medical meetings and there's actually a lecturer, a vetted lecturer that can give a good, well-rounded, highly vetted, highly referenced, information to the community. So I think that's a lot different than maybe 5 to 10 years ago. So I can only hope, and I'm sure you can only also, that this moves forward in a way that really helps to serve our patients well, because, pain is no light thing. And a good portion of our population is really suffering with quite a bit of pain. So this is just one more tool in the toolbox to help with people to do so. Any other thoughts on medical cannabis that you want to share with the audience before I kind of, go into a little more fun stuff on the way out?
Yeah. I actually feel like if you and I are going to keep doing this podcast every few years, each of those podcasts is going to be really different. This is a field that changes overnight. I mean, I turned left and there's another study. There's about 400 projects that are NIH sponsored at the moment that, so this is a rapidly transforming field in front of our eyes. While side effect profile of cannabinoids has been known for quite a long time, and we sort of understand some of them, but the therapeutic impacts, we're like in the baby steps. We're just beginning to discover many of them. So I think it's an exciting field. And I just hope that we will move. My personal hope, and I think, and also prediction, that the sort of a national decriminalization and removing it from Schedule I controlled substance will happen a lot sooner than we think. It may even happen in the next 4 years.
Fantastic. I think it's very hopeful. I'm certainly with you on all of this. I think it's progressive, interesting, and certainly keeping my mind open and looking through the science and all the pilots, because you're doing pilots as well. So I think that's wonderful. So On our way out, I wanted to, ask a couple other things about your interesting home life with your bees. I think many people don't know that you are a beekeeper of sorts, right? And how that plays into some of your community work. I mean, you really are involved in some really interesting charity work in
Yeah.
Washington, D.C. And I think you should, share with our audience what you're actually doing and how the bees and honey play a role in that.
Yeah, so a couple of years ago, we started this entity called AIM Health Institute. If your listeners want to look it up, it's Health AIM, AIM, healthaim.org, to really try to bring integrative medicine to vulnerable patients on Medicaid, Medicare. So we formed this entity, and since I was a beekeeper now for close to 10 years, we said we're going to do this fundraising, a honey drive instead of a money drive, I guess. And so every year around this time, in fact, we have one right now, I produce a few 100 pounds of honey, and then those people who donate money, they get, well, it's kind of late probably for Christmas, but for the New Year's, you can still get a jar of honey from my backyard. It's not organic because I don't know what they collect, but I use zero chemicals. I don't treat my bees. I don't feed them sugar much, just a little bit around time when just before the winter. And so I donate the honey and people donate the money, and we're trying to serve people who are most vulnerable. This year, because of COVID, things gotten a little complicated. We had to pause some of our activities. We had an acupuncture and massage work at local clinic, and their grant had to be put on pause because obviously face-to-face, most of the clinics have shut down some of the activities. So we're trying to redesign ourselves. So we're thinking of doing more of a telemedicine groups and educate people, and also try to bring more mindfulness in people's lives. But at the same time, my 11-year-old, who's this crazy skater, you've probably seen some of his stuff that he does. When Angela, my wife, and I, when we look at this, we're like, it's pretty scary. I mean, those jumps and all the things they're doing with the skateboards, but he's apparently pretty good. And so, but he took on to start telling that a lot of the skaters don't eat right. So, and he loves cooking. So his thing is he's on Instagram, he's a skate chef. So he wants to teach his skateboarding buddies how to eat right. So part of our honey drive goes to that. So
that's wonderful. Look, it's all about educating the next generation. I work with high schools, teaching them about environmental health. I mean, your son's doing a great service. He's teaching his buddies on a venue that they are interested in, these little nuggets of good, healthy living. So good for him and good for you. And I've had your honey. I remember the first time I donated a few years ago, because I do it every year.
Donate, yeah.
I do, but I actually donated thinking I was just donating. And then all of a sudden, this jar of honey showed up, and I said, "What is this? And who sent it to me?" It was the most enjoyable moment to get a jar of real honey.
Yeah. I don't heat it. It's unfiltered.
It's incredible.
It's just pure honey. Yeah.
But what a nice surprise, and what a great way, a sweet, good way to go into the new year, as we hope to have a much better 2021 ahead. I really want to thank you for being with us. Please share with the audience how people could reach you, read about some of the work you're doing. Yep. Certainly healthaim.org is
healthaim.org.
Charity work. So tell everyone how we can reach you if someone to get in touch with you, or even to podcasts or anything.
Yeah, so I think the gwcim.com, gwcim.com is our clinic's website. So you can find my whole bio there. And, if you want to get the honey, then it's a free fire skateboards. So free fire skateboards on what is the app? GoFundMe. But it's also, if you want, we can also put it on your Instagram, and it's on my Instagram and on my Facebook. Of course, I'm on a Facebook. I'm as a Misha Kogan on a Facebook, not as a.
So people can follow you just as a physician and just learn what you post, and that's great too, because you're sharing really wonderful articles and information and commentary. So I think that's great. And then also there's the podcast from George Washington University, has an integrative medicine podcast that's now launched. So if you're interested in listening to more lectures on integrative medicine, I think that's going to turn out to be a wonderful podcast. I know it's
we're going to have you on that podcast soon enough.
Yes, I'm
Next
scheduled and
year.
I'm
Yeah.
excited. I think this is a really fun way to share information. So, but thank you for spending, your time today and opening up our minds to geriatric medicine and understanding how that works, how it affects COVID, and then, certainly medical marijuana is a really hot topic and it's evolving. So, thank you for being a messenger for all of that. Really hope to see you soon, healthier, happier, new year, all safe and well. And so, thank you for being here, Misha.
Very, very happy to be here. Thank you, Ali.